Breast-specific gamma imaging captures metabolic activity in the breast, aiding in the differentiation of benign and malignant lesions. With negative predictive values consistently in excess of 96%, BSGI is the ideal complement to mammography for the difficult-to-diagnose patient. BSGI is a strong adjunct, especially for patients who present with equivocal mammograms, dense breasts, scar tissue, implants, hormone replacement therapy, palpable lesions not detected with mammography or ultrasound, and high-risk patients with a positive family history. The following cases demonstrate not only BSGI's multiple indications for use, but also several instances where BSGI made a significant impact on diagnosis and treatment. Dr. William Boren is the co-founder of the West Valley Imaging Centers in Las Vegas. He built the premier radiology practice on the philosophy of providing his patients the most advanced imaging technology available. While West Valley provides comprehensive imaging services, there is also a strong focus on women's health care.
So here on the right, we see that there is uptake demonstrated in the right breast. This is the same area corresponding to the lesion we biopsied. However, surprisingly, a lesion showed up near the nipple, which was not easily seen on mammography. Using calculations from the marrolumiscan and the mammography, we did a stereotactic biopsy, and this turned out to be positive for ductal carcinoma. So 2 foci were seen. The second foci was not visible by mammography. On the left, this is a mammogram of a patient who's had silicone injections. Here you can see the silicone, some calcifications associated with them, but basically an unreadable exam. This patient's had an unreadable exam all her life since the injections. We did a marrolumiscan, felt that we had nipples activity and no other activity. For the first time, she got a negative study. Here, the mammogram on the left demonstrates implants as well as dense breast parenchyma surrounding it. We did a marrolumiscan because she had a palpable lesion that was not seen. On the marrolumiscan, the photopenic area represents the implants. The increased tracer uptake here represents normal breast parenchyma, and then we had an area of focal increased uptake. This turned out to be a ductal carcinoma. The mammogram in the bottom left is MLO views of a 22-year-old. We just do MLO views on patients below 30 years old. She had multiple palpable lesions. These were ultrasounded, and although they appear as though fibroadenomas, we did a marrolumiscan and there was normal uptake. On the left is a mammogram of a patient who had multiple masses. Very, very dense. Ultrasound showed these were complex lesions. Uptake was demonstrated in 5 locations, some of which were seen, some of which are not seen. We biopsied the 2 largest ones in each of the left and right breast. Both of these were positive for phylloides tumor.
A board-certified radiologist, Dr. Craig Thiessen, is the managing partner and medical director of West Houston Medical Center. Dr. Thiessen started in family practice and continues to be committed to delivering personal patient care. Breast imaging is important at West Houston. Dr. Thiessen and his partners have witnessed a significant improvement in breast cancer survival rates over the last several years, and they actively search for innovative tools to increase their medical acumen.
With BSGI, there are multiple indications. One of the main indications is this patient, a 46-year-old female with a positive family history of breast cancer, who presents with a palpable abnormality in the left breast, which is somewhat vague. The mammogram done earlier shows the usual dense fibroglandular changes without any specific dominant mass lesion or group microcalcification. The patient then has a follow-up ultrasound which shows multiple round benign appearing hypoechoic lesions at 2 o'clock, 12 o'clock, and 11 o'clock. The surgeon's question is which one to biopsy, and therefore we suggest breast-specific gamma imaging. With the biodistribution of the agent, you notice the nice homogeneous pattern in the breast in both the ML view and the CC view without any focal activity noted in either breast to suggest a negative study. With this negative study, we have a higher level of confidence such that after talking to the surgeon, we were able to tell him that the patient can return for a follow-up mammogram and ultrasound in 1 year's time, negating that usual 6-month short-term follow-up unless the lesion obviously became larger. This is another interesting case for breast-specific gamma imaging. This is a 50-year-old female who comes in quite concerned for her routine annual mammogram with a strong family history of breast cancer, multiple previous biopsies, all of which have been negative. Previous mammograms have been lost by another institution. Her mammogram on routine evaluation shows dense fibroglandular changes with multiple spot calcifications with spot magnification views showing no definite group microcalcifications. Due to the patient's concern and anxiety, it was felt that perhaps breast-specific gamma imaging may give this lady a level of reassurance, and it was therefore carried out. Unfortunately, the breast-specific gamma imaging showed a focal area of increased activity in the left breast in the subareolar region at approximately 6 o'clock. The patient was therefore brought back for ultrasound of the breasts. Ultrasound did show an oval, benign-appearing hypoechoic solid lesion in the left breast at 6 o'clock. Because the lesion was correlated with the abnormality noted on breast-specific gamma imaging, it was biopsied the same day. The biopsy came back as intraductal papilloma and atypical ductal hyperplasia requiring excisional biopsy, but obviously the breast-specific gamma imaging has added a great deal to this difficult mammogram.
Dr. Joshua Gross is Chief of Breast Imaging at Beth Israel Medical Center in New York City and is the Director of the Breast Imaging Fellowship Program. Dr. Gross has made significant contributions to breast diagnostics and nuclear medicine for over 20 years.
This is a 63-year-old female who presented with a lump in her left breast. This patient had mammography approximately 1 year ago, which I'm going to show you up here. In June of 2004, she had a lump in the left breast, which was seen as a mass here. This was biopsied and was reported to be a papillary lesion. She had surgical excision, and there was some ductal carcinoma in situ within this nodule. So all she had was surgical excision. She did not have any follow-up radiotherapy. The patient then presented a year later with a new lump in the same general location. This is the mammography from June 2005, and we see post-surgical scarring here, and we don't see any lump. She did have directed sonography, and the lump is seen here as a solid mass. The mass measures approximately 1.1 centimeter in diameter. Biopsy was done, and this was also a case of ductal carcinoma in situ. Prior to the surgical excision, the surgeon wanted to do breast-specific gamma imaging to determine if there were other lesions present. The patient was injected for the gamma study, and these are the images. What we see here in the left breast on the CC view are multiple areas of abnormal activity. They're in the lateral breast on the CC view, and on the MLO view, they're in the central breast. So basically we have activity, abnormal uptake of radiotracer in the ductal system on the left side in the central and outer breast. The right breast demonstrates normal homogeneous activity. The question is, what is this abnormal activity in the whole ductal system? Because the lump itself only measured approximately 1 centimeter in diameter, whereas the Dilon scan is showing a much greater area of involvement. We took the patient back to sonography and looked for other areas and even biopsied some ducts in the region of what we thought was the abnormal activity, and those biopsies were negative. The surgeon then went to excise the palpable carcinoma, and he took an extensive piece because of the abnormal Dilon scan showing greater abnormality than we suspected. Well, the pathology on the 11 centimeter specimen was low-grade ductal carcinoma involving the margins. In other words, the gamma-specific imaging demonstrated a much larger area of involvement than suspected on mammography, on sonography, on palpation. And what's very interesting is that this abnormal activity corresponded with low-grade ductal carcinoma. In other words, we only expected to see high-grade or invasive carcinoma with the breast-specific gamma imaging, and in a situation such as this, we saw extensive abnormal activity in areas of low-grade ductal carcinoma. So the Dilon scan was extremely helpful in telling us that this lesion was much larger than we had suspected.